So with that, we're going to move on to atrial fibrillation. And I'll introduce John Amarina, who's going to talk to us about a couple of trials. John.
Okay, well, thank you, Phil, and thank you for the organisers for inviting me to talk about atrial fibrillation. I'm going to present two studies tonight that have been presented at the ESC over the last few days. And the first involves the use of digoxin in patients with heart failure versus beta blocker. And then the second is whether we should adopt a rate versus a rhythm control approach early rather than late. So the first study I'll review is the rate control therapy evaluation in permanent AF, which is was presented by Deepak Katecha a couple of days ago. The theory, the basis for this study was that in the UK there's an increasing prevalence of atrial fibrillation in an older and older population, and they've recognised that from an analysis they've done and published that the mortality in patients with AF has really not changed over a long period of time. So you can see both the curves for younger and older patients with AF have really been flatlined over at least a decade. They've also thought that about 50% of patients with AF have permanent AF, but there's been very little research into the group about what the best therapy is, in particular with respect to rate control. And they've suggested around 50% of patients with AF will develop heart failure over time, and that there's no really randomized trial data to help choose what's the appropriate rate controlling therapy for them. An analysis presented about 5 years ago at the London meeting by the same group looked at the effect of beta blockers in patients with atrial fibrillation and heart failure. We've really got very clear evidence that in patients in sinus rhythm with heart failure benefit from beta blockers in terms of mortality. But the large analysis they did, a meta-analysis, wasn't able to demonstrate that there was a benefit in mortality with beta blockers in patients with heart failure and atrial fibrillation. Conversely, digoxin, there's been a lot of observational studies and basically have suggested some benefits, but the only randomized clinical trial that did study was not able to show any benefit of digoxin in rate control for AF in heart failure, but there was a decrease in hospitalization. So really there's not a lot of hard data looking at the effect of digoxin in these patients with heart failure and AF. The design of the RATE AF trial is outlined here. So the question was, should beta blockers or digoxin be used for long-term heart rate control in patients with permanent atrial fibrillation and symptoms of heart failure? It was prospective, randomized, open label, investigator blinded endpoints, and it was developed by a patient and public involvement team. Patients who are 60 years or older with permanent AF and symptoms of heart failure, NYH2 or above, were included if they needed rate control for AF. The exclusion criteria were minimal, so it looked as generalizable to the population, and in particular there was no heart failure or EF ejections apart from recent decompensation. The primary outcome was looking at the quality of life using the SF36 questionnaire and the physical component summary score at 6 months, and secondary endpoints are changes in heart rate, the EHRA symptom classification for AF, NT-proBNP, quality of life, ejection fraction, and clinical events. So this is the diagram of the patient flow through the study, and I don't want you to read it, but in summary, they enrolled 160 patients, which is a pretty small number. They had a randomization algorithm to try and ensure the groups were balanced, but we haven't seen any data about what the characteristics of each group were. Presumably that will come out when the paper is published. The mean age was 76 years, 46% were women. Most had moderate to severe symptoms of from their atrial fibrillation, and 52% had signs of heart failure at baseline. Their NT-proBNP was elevated, and 19% had an ejection fraction less than 50%. And they've said the groups are well balanced, but we haven't seen that data. They met the sample size calculations for the primary outcome, and in 6 months, the majority of patients were taking digoxin, and the majority, a few less, a smaller percentage, taking beta blockers. And at 12 months, the vital status was known in all patients. So basically, the patients were randomized to either beta blocker or digoxin as a means of rate control in AF. And the first thing of interest was that there was really no difference at baseline between the heart rate and at the end of the titration, 6 months, 12 months. So it appeared that the patients, at least at rest, had similar rate reductions with beta blockers and with digoxin. There wasn't any excess of bradycardia in the beta blocker group compared to the digoxin group, and their Holter monitors were pretty similar. When we looked at the primary outcome at 6 months, this is basically the quality of life and the functional score. Digoxin patients seem to do better in general, not enough to be statistically significantly different, but they certainly appeared to do better than the patients on beta blockers. In the secondary outcomes, basically at 12 months, digoxin was superior in a couple of the domains, which I'll show you now. And that looked at the improvement in AF symptoms as judged by the EHRA functional class. And the diagrams with the funny lines are difficult to interpret. But if you look at the bar graphs, basically the patients who have received digoxin for rate control in heart failure had a significant improvement in functional class and symptom control compared with the patients who received beta blockers. The other things that were of interest were the patients who were randomized to digoxin had a decrease in their functional class according to the NYHA criteria from 2.4 to 1.5, which was a little bit better and significantly better than patients who received beta blockers, where it went from 2.4 to 2. In terms of changes in NT-proBNP, patients in digoxin had a significant drop in NT-proBNP over the 12-month period, and the beta blockers had a significant increase. So that seems a bit counterintuitive, and I'd be interested in people's thoughts as to why that should occur. And of interest as well was the patients who received digoxin had patients who were on beta blockers. Some of the patients were on beta blockers, and when they went into the trial were changed to digoxin. And despite that, there was no deterioration in LV function over 12 months, whereas in beta blockers, it remained pretty static. So that was surprising that the patients who were randomized, who were on beta blockers and were randomized to digoxin, had no deterioration in LV function. So they also looked at adverse events, and basically the blue bars are beta blockers, the orange bars are digoxin, and as you can see, these were pre-specified outcomes. Most of them were in favor of the patients who received digoxin in terms of deaths, although not enough to be significant. CV events, unplanned admissions, serious adverse events of any time, etc. And so again, somewhat surprisingly, patients who received digoxin seemed to do better clinically than the patients who received the beta blocker-based rate control therapy. So the question was that should beta blockers or digoxin be used for long-term heart rate control in patients with permanent AF and symptoms of heart failure? Basically, they said there was a similar effect on heart rate, a similar effect on quality of life, but if anything better with digoxin, and they had better symptom improvement, reduction in natriuretic peptides, and substantially less events without compromising cardiac function. And their conclusions from this analysis was that the digoxin could be considered as a first-line approach in patients with AF and heart failure as an alternative to beta blockers, given the results here and their previous study that showed the mortality benefit of beta blockers in patients with heart failure and AF was really not evident. So my comments and thoughts about this study were that it was a pretty small sample size. You only had 80 patients in each group, and the endpoints were not really all that hard and weren't powered enough to look at hard endpoints, but the data was persuasive. There was not really any data on the change in heart rate with exercise, which is supposed to be better with beta blockers, but the question is, does that really matter given the results of a study like this? There was no data on digoxin levels, and in previous studies this has been an issue, particularly in older women with heart failure, where there was the decreased outcomes in patients, and so we don't have any levels in this study at all. That may come with the publication, but nothing reported to date. There was interesting data that no change in ejection fractions when beta blockers were replaced by digoxin. There was interesting that BNP was decrease in BNP was better with digoxin than with beta blockers. And I suppose it supports the use for digoxin in rate control for AF in heart failure, particularly in patients who can't take beta blockers or can't tolerate them for whatever reason. It would really be nice to have some prospective clinical trial data to base this, to confirm the results of this study. I suspect we'll never get that data because all these drugs are off patent. It would have to be an NIH or a NHL LBI to do it, and I think that's probably not going to occur. And it still doesn't answer the question of what's the use of digoxin in patients with heart failure who are in sinus rhythm, and we probably won't ever get a real answer for that as well. So that was the first study. And so if we progress to the next one, Phil, and then have questions. Okay. So, Yep. Okay. So the next study, again, is the EAST study. So early rhythm control therapy in patients with AF. And this was presented again a couple of days ago. And I'm grateful to Georgia for getting the screenshots because the slides weren't available on the Congress 365. So the theory with this study was looking at strategies for patients who've had relatively short-term AF. So they had patients who are at risk for cardiovascular events and all have had a CHA2DS2-VASc score greater than 2, recent onset of AF, which was defined as having been of less than 1 year's duration or first documented by ECG. And patients were randomized into an early rhythm control arm, which included anticoagulation, rate control, and either antiarrhythmic drug therapy or ablation. And in the case of recurrent AF on drug therapy, ablation was used. Usual care was anticoagulation, rate control, supplemented by rhythm control only in patients who were symptomatic with good rate control. The sample size and power was a probe design, so a prospective randomized open blinded endpoint assessment. The two primary outcomes were the composite of CV death, stroke, worsening heart failure, or ACS, and the second co-primary was nights spent in hospital per year. They assumed there'd be a 20% reduction in the first primary outcome and powered it to have 80% to detect a 20% improvement. There was an events review committee. Sample size was estimated at 2,800 patients, adapted to 2,745, and there were some interim analyses, as we would expect. This, again, is a little hard to read, but basically the average age in years was around 70. About nearly 50% were females. They were a little overweight, but not greatly. The average CHA2DS2-VASc score was 1.4, 3.4, and the stable heart failure basically with an ejection fraction less than 50% in class 2 or 3 symptoms was in about 28 to 30%. About a third of patients had first episode AF, third paroxysmal, and a third persistent, and about 50% were in sinus rhythm at baseline, and the time from the AF diagnosis was an average of 36 days, and basically, it's difficult. Without AF-related symptoms, we had about 30%. So basically, there were patients who were older, 70 years of age, who had symptomatic AF in general, and a lot of them were in sinus rhythm when they were enrolled in the study. Medication usage is pretty standard. Anticoagulation in the majority, digoxin in a small percentage, beta blockers, ACE inhibitors, statins, etc. Pretty standard therapy for this type of age group. So this is the consort diagram of the flow through the study, and I don't, again, want you to read it, but it's important to recognize that the patients who were randomized to the rhythm control arm, 25% of patients were either on propafenone or dronedarone at the end of 12 months, and we don't have either of those available. And I must admit, I'm surprised because I thought dronedarone had died a sudden death after the Pallas and Andromeda studies showed it actually increased mortality. But apparently in Europe, it's still being used as a rhythm control agent. About 8% had an ablation at the end of 12 months. At 2 years, the rates of propafenone and dronedarone had dropped, and the rates of ablation had increased. In the rate control arm, there was a low use of antiarrhythmics at 1 or 2 years, and this was in patients who'd become symptomatic and had good rate control but were still symptomatic, and they were transferred to a rhythm control strategy, and around 7% had an ablation at 2 years. This is the result of the trial. So basically you can see that the early rhythm control strategy in blue had a significant improvement in outcome compared with the usual care. And the primary outcome, I'll remind you, was CV death, stroke, worsening heart failure, or acute coronary syndrome. Now, the magnitude of the effect is there. It's an absolute risk reduction of 1.1% per year, meaning that you would have to treat 91 patients to save one of those events per year. So that's certainly significant, but I would wonder if that's really clinically significant. With respect to harder outcomes, CV death and stroke was certainly significantly reduced to the amount that you can see here, whereas hospitalization with worsening heart failure was no difference between the two strategies, and hospitalization for ACS was not different as well. In terms of subgroup analysis, there was really nothing that stood out, so we don't need to dwell on that. And in terms of key secondary outcomes, the majority of patients, well, firstly, the nights spent in hospital, really no difference between the two strategies. Sinus rhythm was more frequent in the patients who had a rhythm control approach, and symptoms were pretty similar between the two groups, whether it was early rhythm control or rate control. Other secondary outcomes, change in ejection fraction was slightly greater in the patients who received the early rhythm control. The change in quality of life, again, was better in the rate control rather than rhythm control, and mental score, physical score, etc. were a little better they're mixed results. In terms of safety outcomes, as we mentioned, the rate of stroke and death was lower in the patients who received the early rhythm approach, but the price you pay is adverse effects related to the drugs used. So there was a significant increase in bradycardia and AV block, in drug toxicity, etc. So as we've seen in the early AFFIRM study, where the the benefits of maintenance of sinus rhythm were counteracted by the side effects of drugs. We saw the same thing here. Obviously, the patients who had ablation had more adverse effects compared to those who didn't. And there are other adverse effects, that hospitalization for AF, that were pretty similar between the groups. So the conclusions were that early initiation of a rhythm control therapy reduced CV outcomes in patients with early AF and CV conditions without affecting nights in hospital. The early rhythm control strategy was associated with more adverse events related to rhythm control therapy, but the overall safety was pretty comparable, and the results have the potential to inform the future use of rhythm control in patients with early onset AF, that is less than 1 year. So my thoughts on this were that it's a good study, but whether it's applicable to Australia is difficult to know, because propafenone and dronedarone are not available here, and that was at least 25% of the rhythm control strategy that was used in these patients. We would use sotalol and flecainide. Well, flecainide use was about 50%. Sotalol, there was no data on, and we would use that as an alternative to propafenone and dronedarone. There's no data on that, and we would try and avoid amiodarone in this age group due to the risk of side effects. To save one of the events, ACS, worsening heart failure, stroke or CV death, you had to treat 90 patients per year to save an event. So it's statistically significant, but is it clinically significant is an open question. The price you pay for early rhythm control strategy is the side effects of drugs and complication of ablation. But it is reassuring that you can use this strategy with small improvements in outcome, but at the expense of adverse events. And the other thing that's a little different from an Australian perspective is the relatively high use of ablation in this age group. Remember, the average age was 70. So in the rhythm control strategy, 19% had had an ablation at 2 years, compared with 10% in the rate control strategy who crossed over. That would seem to be higher, at least in a Victorian context, that patients would get ablations in that age group of that frequency. Perhaps they should get it, but the reality is in Australia at the present time, with the resources we have, ablations generally reserved for a younger population with paroxysmal symptoms or heart failure, rather than this group of patients. So I'll finish there and be interested to hear your thoughts and answer any questions.
Yeah, well, thanks, John. I'd like to bring Chris Hammond in now. So, John, we haven't got a lot of time for discussion, but I gathered from your comments this probably hasn't changed your practice. Is that correct?
Yeah, I don't think. For digoxin, I think it'll have an increasing part to play, particularly in patients who aren't tolerating beta blockers terribly well in AF and heart failure. But I would still, I don't think it'll make a big change to me. No, either study.
Chris, do you like to comment? Will either of these studies change your practice?
Just check you can hear me, Phil, because we were having problems earlier.
Yeah, we can hear you.
Oh, thank goodness.
Yeah.
First of all, the digoxin study is interesting because we've had such negative press about it previously. It's such a small study, though, it's hard to know what to make of it. So the biggest worry is, of course, the mortality signal, or the supposed mortality signal with digoxin. And a study with just a couple of hundred patients really can't tell us one way or another if it's going to have, serious adverse effects and a mortality signal. You need a much bigger study to know that. So, it makes people feel better. Other drugs we've used before have made people feel better but killed them. So I'm not sure that it answers the big questions we need answered, and that concerns me. The rhythm control is interesting because, again, that's had bad press from a firm and from previous studies. But for the first time, we actually suggest if we can get early rhythm control going, then we can reduce not only frequency of AF, but also potentially hard outcomes like mortality. So yeah, I understand the resourcing problems and the difficulty of doing it, but I take it back to if I had onset of atrial fibrillation, I would want to go with this strategy and try and stop this being a permanent long-term problem with all the downsides. So I thought it was probably a breakthrough study, and when you put it on top of the other ones, I think it suggests that ablation and rhythm control is a very important strategy.
Okay, we haven't got a lot of time. I just want to draw you both out on the anticoagulants. Most of our conversation around AF over the last few years has been about anticoagulation. There was a study which demonstrated that we haven't improved the uptake of anticoagulants very much, and even mailing out from providers and insurance companies didn't change anything if you only do it once. But I want to ask you, both of you, where you see the anticoagulant situation is at the moment, particularly in the people with renal failure. Cardiologists now seem to be having to learn a lot more about the kidney, the SGLT2s. We're giving people with much lower GFR than originally. And there's a bit the same conversation with the anticoagulants. So, Chris, you're one of our anticoagulant experts. Where do you see the role in people with impaired renal function these days?
Yeah, I mean, it's been an interesting journey because renal failure is very difficult. It has high bleeding risk, but also high ischemic risk, high stroke risk. And when we first came out with the NOACs, we emphasized caution. We said be very cautious of using them, monitor renal function very carefully, go back to warfarin if renal function starts getting down around lower CKD3. But when you look at the drugs, that doesn't make sense because there's only a very small increment in drug levels and anticoagulant effect as renal failure progresses, even right down to end-stage renal failure. And when you look at some of the data coming from overseas, using it in people with severe renal impairment seems to have fairly favourable outcomes. Because we were faced with a paradox. We had the situation where we'd have patients established on a NOAC, and then when their renal function dropped below that magical number of 30 mils per minute, we somehow had to either abandon anticoagulation even though they had a high stroke risk, or we had to put them back on warfarin and treble or quadruple their intracranial hemorrhage rate. So I think, luckily the TGA has seen sense recently and have said, look, we accept all of this theory, we accept the data coming from overseas, albeit non-randomized, and have allowed us to use NOACs in that space of more severe renal impairment. And I think you've got to be cautious, you've got to weigh up the bleeding and stroke risk, but we shouldn't shy away from protecting patients in that field.
Yeah, and Phil, there has been some data with Eliquis or apixaban in patients on dialysis proving that it's safe to use. It's not outcome driven, but safety. And as Chris was alluding to, the TGA has recently, and PBS have recently allowed rivaroxaban to be used down to an EGFR of 15, which it is in other parts of the world. So that gives us a bit more freedom to use that agent in patients with an EGFR between 15 and 30. It's a difficult population. There's a lot of debate within the renal circles as to the benefits of anticoagulation in populations with end-stage renal disease, as the bleeding risk is higher. The efficacy in stroke is a bit dubious, particularly with the warfarin studies. So there's some hesitation, but I think it gives us, with this new indication, it gives us more flexibility and more ability to treat patients with lower EGFRs to try and reduce their stroke risk.
Okay, well, I think we'll wrap up the AF segment
Phil,
now. Sorry, Chris.
Yeah, I just want a final comment. I think the end-stage renal failure on dialysis, that's a completely different matter. They have much bigger problems than worrying about stroke risk anymore. But I think the people who are CKD4, they can be stable in that zone for a long period of time, and they do have a high stroke risk. And I think protecting them with anticoagulation is sensible for the majority. And I'm glad we've been liberalised in terms of being able to do that.
Yeah. No,
okay, great. I think we'll move on. Thanks for that contribution on AF to John and Chris.